kind of like pull apart a little bit. So we want to make the laceration deep enough to be like at least a little bit not approximated, so you guys get a chance to practice suturing, but not so deep that it's like you're going to be here all day, you know. And I've got my pictures to show you guys later if you want to see them, of various things. So I'm going to make a few smaller ones. You can decide, this is your skin, you can decide what to do with it. But you can either make like multiple kind of small lacerations, or you can make a big one and take the material out at the end. It doesn't matter to me, okay? So I'm going to make a few small ones. So everyone kind of see how, like, you can see white underneath there, but you can't see red. So like red is probably a little too deep, and white is, this is probably good for like the superficial ones. When we talk about subcuticulars, we might go a little bit deeper so you guys get a chance to practice kind of passing that needle through multiple layers, okay? So we've got our laceration. A very helpful ER tech already cleaned it for us. So we're gonna pull our suture material out. So when you pull out the suture material, the needle usually comes first. There's a couple, like those on the other package that I was showing you, that one, yeah. You can actually see the needle right here, okay? And so you just have to open the outside package and then pick up the needle. So you never want to be touching the needle with your hands. So the two tools you're going to use are, you're going to use your forceps or your needle driver, okay? And you're going to use what we call like rat tooth forceps, or rat tooth, yeah, forceps. And if everyone can see, they have little rat teeth on them. Anyone know why we use rat teeth on skin as opposed to smooth? Not exactly, but close.
Tap on.
Yeah, so so you guys are on the right track. I mean, you can see very clearly that this is different from
There's more
Doesn't it give you better?
from this, which are smooth, right? Where they have tiny little like grips, but not really like anything else. So the reason for these is that it's better to pierce the skin than it is to mash the skin. So with this, when I pick up the skin edge, I'm going to be like piercing. Like you can actually, like if you come really close, you could see that there's like a little hole that I make in the skin. But that is opposed to making a big indentation in the skin. So that heals slower and causes more necrosis and tissue damage than making a single rat tooth hole in the skin. Okay? So you are never to handle a needle with your bare hand or with your hands. You always handle, we are doing instrument driving and instrument ties and everything instrument based in this class. So you will pick up, like you could pick up with the smooth ones if you want to, and if you need to adjust your needle, you need to pick it up with a tool in one hand and the needle driver in the other, and reposition it. Make sense? So in this case, like it's going to be kind of down, so I can go ahead and pick it up with, and you just pull the whole suture out. Then you're going to take some form of forceps in order to line it up. So you want your needle driver to be on kind of the back third of the needle. You can kind of straighten out your suture a little bit if you like. I like to do that, just to kind of like make it sit a little bit better. You want it to be on the back third, not all the way at the back because you're going to lose dexterity if it's like all the way at the back, but too far forward you're going to lose throw. So you won't be able to make as big of a bite or as big, a deep a bite. Does that make sense? And so then once you have it positioned, and then the other thing is you want it to be right on the tip of your needle driver. So you don't want this to be like choked down like this. You want it to be like right on the tip, just like this, because that's also where you have the greatest flexibility and dexterity. So you want to have it as like close to the tip as possible. Your finger placement is important. So you don't want to do this like children's scissors, you know, where you put your fingers like all the way in, because then what are you going to do when you get it in? You're going to have to like, and then it's going to fall out of the skin, and then you're going to be like, oh, this person thinks I'm incompetent and all that, you know, all that stuff. So instead, tips of your fingers. You have a finger in each one of the finger guides or the hand holds, right? And then the others are the ones that are going to guide you're throwing. You're suturing. Suturing is a wrist movement. So it starts out like this, and you show yourself your palm basically on a standard simple interrupted suture. There's obviously a few exceptions to that, like we talked about, some of the specialized sutures that we're gonna do in class. But in general, you start out like this and you throw towards yourself. Okay? The other thing to keep in mind is that because we already talked about the fact that these are cutting needles, right? You want that cutting tip to be the first thing that enters the skin. So you don't want to skive. You don't want to enter the skin like this. It'll still cut, but it's going to be a different kind of like size opening. So you want to start your cut with the needle tip facing down. Does everyone see that?
Mm-hmm.
So the first thing you're going to do is you're going to evert your edge just a little bit. This is for a simple interrupted. That's what we're going to do first. You position your needle driver so that your cutting tip is down, and you throw towards yourself. Okay? Now what?
You pull it with the forceps?
Right. So this is where your finger placement is important, because I'm going to release my forceps. And if you oftentimes what they'll teach you, and I don't do this as often anymore because I'm lazy, but you should grab your needle tip with something, but you don't want to grab it too hard because you might dull your needle tip. So you want to be careful about how you're grabbing it. Then you're going to reposition your needle driver and pull it through the initial skin. Then you're going to reposition your needle driver again so that you're ready to make your second pass. So second passes through the second layer of skin. Same thing goes. You want to put it in cutting edge first. Evert the skin edge so you can see what you're doing. Release. Maintain control of your needle tip, which again I'm not very good at, but you get the general idea. Pull it through with a driver, just like that. Short end, but not so short. Okay. Be careful where you're putting your needle, needle end. So a lot of times you want to make sure it either wants to remain on the sterile surface, or you want to control it somehow so that it's not just about anywhere. Okay? Because you would hate to put your hand down on your needle, right, or something like that if you really reposition. So now we're going to talk about instrument ties. Does this look like somewhat familiar and reasonable to everybody so far? Okay. Please speak up if you have questions, and obviously we'll be all walking around and talking about it as well. So your instrument tie starts with a surgeon's knot, a double, like a friction knot, a double knot, okay? So you make 2 throws around your needle. So you put your needle on the laceration side of your suture. Mm-hmm. Wrap. Sorry, but you want to avoid the hinges of the driver because it's going to catch your suture. Then you reach across and you just nip your little end in the tip of your needle driver, and you pull the whole thing off. Make sure, and then you notice me jiggling it. That's to make sure that the knot lies flat and straight. Okay, so once that happens, you pull tension until the wound closes. And then again, laceration side, or like the inside of your thread. This is going to go back and forth. So you're basically creating like back and forth knots to create the best chances this knot will stick. Because we already talked about how this material is a little more slippery than others. So this is a single wrap. Wrap once, grab, pull. Wrap once, pull. 3 to 4 times. Okay. Wrap once, pull, tighten down. Once you're satisfied, oops, sorry, I'm so sorry, I didn't mean to elbow you. You have a pair of scissors included in your kit as well. So the scissors, you cut off the needle edge of the suture, and then you can trim up the other end if you're a nice person. And you have one suture. Snap. Okay, so, oh, I forgot. I'm not allowed to touch the needle with my bare hands.
We didn't see anything.
Yeah, you guys didn't see anything. That's right.
That's right.
You got it all on video.
We're gonna have to talk about that video. Okay, so makes sense to everybody? I'm gonna move on for the sake of time rather than doing like the whole laceration as like simple interrupted. I'm gonna move on to the next type. So simple running is next. Very similar to what we've just kind of done. Should be like pretty easy, and it's like basically like if anyone has any rubber sewed, it's basically like a whip stitch. So all you do again. Same beginning steps. So you pierce the skin, and sometimes if the laceration is well approximated enough, you can do this all without pulling the needle all the way through the skin. Like you can make 2 throws. Also worth noting, like, do you see how even my throws are? Do you see how it's an equal space? So probably about the tip of the forceps or tip of the needle driver from the edge of the wound is acceptable. If you're too close, it's going to go through that friable tissue and it's not going to hold. If you're too far away, it just looks gross, and it also can cause like tissue necrosis. Okay, so once you have your initial throw, you pull through, just like that. You control your needle, however you want to do it, and then you're gonna anchor this.
The two one?
Yeah, so same thing, same exact thing. You start it the same way as you start a simple interrupted. Anchor. 1, 2, 3. Oops. So I make mistakes too. Yeah. The suture will slip, your hands will shake, it'll be fine. Once you finish that though, you're not going to cut anything right now. So you're going to capture your needle again. And I have a friend who works in surgery, and she's like poetic at these, but I am not quite as good, so forgive. Hers are like, they could make a grown man cry, like seriously, they're beautiful. So all you're gonna do, control your needle, or I mean your thread, is you're gonna start moving like this. And then, this is a new technique, you're going to reverse the throw of your needle. So that was not the cleanest reverse, but you're going to reverse the throw, and you're going to reverse your hand placement so that you can then come back through. Oh wait, no, I'm sorry. On these ones, you're gonna keep going the same. So you just keep going across. I ignore that last part. I forgot that this is just simple running.
So you're not gonna tie.
So no tying, no. Or tying at the end, but you're just gonna keep throwing through just like that,
Okay.
and you see you end up with a lovely little like kind of running stitch. Okay.
How far from each other should
So,
this meter?
so that's a good question. In general, you want to be you don't want to be so close that it's obnoxious, especially to remove them. You want to be close enough though that there's not like you can't gap the skin in between. So a lot of times what I'll do is I'll come along after I'm done, and I'll do this, and I'll just test the tension of the wound. And if there's a big gap, I'm like, oops, missed a spot. Go back and fill it in, kind of with another suture. But in general, like this is usually acceptable. Like maybe, what is that? Maybe like a 1/4 inch between sutures, or maybe like, is that a 1/4 inch? Is that a 1/2 inch? I don't know.
Quarter.
I can't tell differences. I've like, or I can't tell distances. So.
Just testing, that ain't change. Relax.
I like it. Very resourceful.
We told us to like get a size of your body.
Yeah,
to be
that's
cultured
right.
on
Yeah.
this size.
This is an inch. Everybody's.
Yeah.
point
So everyone
to
see
it.
that?
Wow, that's so pretty.
But now notice it is diagonal, but I'm coming back and forth straight because the straight part is underneath. And the diagonal part ends up on top. So I am not throwing diagonally, and that's an important consideration. So if you throw diagonally, you end up with straight stitches on top, which is fine, but these look prettier.
Yeah. Aesthetics.
Yeah, that's right. So again,
This is
I know Justin's commentary is really like cracking me up over here. So like that, and you just, again, you do give it a gentle tug to pull some tension into it. When you're done, then you can do one of two things. So you can either like anchor it, tie it against the skin as like a single knot, or you can do a triangular closure. So in that case, you put it through one side of the skin. Let's see if I can remember how to do these. This is like a surgical the surgical technique. So I should actually cut my needle off before I do this, but you're going to like make a triangle and pull it through, and then pull it all the way through and pull down. Everyone kind of see how I did that? So we can go over that a little bit more in smaller groups because it's hard to kind of demo up front, like exact, but then you do the same thing, like 3 to 4 pulls, and then you cut your edge off. Yeah? Okay. Oh, mattress sutures, is that next? Yeah, mattress sutures, then subcuticulars, and deep dermals. We need to do deep dermals too. So we need to do 2 mattress sutures, a deep dermal, a subcuticular. Okay.
And this one is the mattress.
Yeah, so we're gonna do mattress sutures, both mattress sutures.
And the last one you did was,
So simple running.
thank you.
Yeah.
I just, for documenting.
I keep getting these like Professor Hudson sent me some pictures of me last week, and I'm like, oh, the paparazzi, you know, like are out, you know. I feel like a kind of a celebrity. So, worth noting when you cut with a scalpel, you kind of want to stroke the blade. Remember, it's thick enough, or I mean, it's sharp enough that it's going to go through skin. Okay, so you don't want to just sort of like stab in and start like sawing up and down. You want to stroke along the layer or the plane that you want to create a hole on. So I'm going to make this one a little bit deeper. Because remember, we talked about mattress sutures being good to bring like areas of tension together. Okay, I'm going to use a little bit of my. So remember far, far, near, near? Okay, that's what we're going to start with. So if I have this cut, I'm going to go far. So far. Okay, these ones often you will not be able to throw 2 at a time. Okay, so you're going to pick up with something likely on these, because otherwise you'll lose your needle tip inside the wound and it'll be hard to find. It's not going to disappear. There's nowhere for it to go, but like it'll be hard to find and it will slow you down. So far. You pull it out enough that you can grab it and control it, reset, and then far. So again, everything is equidistant. So notice like I'm about equidistant. Like it doesn't have to be precise. You don't have to get out like your measuring tape or anything. Some of you might, so I have to tell you that. Yeah. So far, far, right? So we've got far, far. And then we're going to do near, near. So this then is when you're going to learn how to reverse your throw. So everyone see how I reversed my needle direction, right? Now I'm going to reverse my hands so that I can still throw accurately. Yeah? Near. And near you might be able to get away with doing 2 at once. Okay? Then same thing, instrument tie. So 2 throws. Make sure that your knot is straight and flat, because if it isn't, I'm going to come find you. Throw. All I can hear is you behind me going, beautiful, beautiful. every time I do
Just so
something.
smooth, you know? I want to look like that.
When you grow up, no, I'm just kidding. Okay, so what kind of mattress is this? Vertical mattress, right? Because remember we talked about it being perpendicular to the throw of the laceration, or like the direction of the laceration. Yeah. So then horizontal. Horizontal, I don't do quite as often, but.
Hey, I don't need to document
I do like only verticals. Okay. It is hot in here, isn't it? Okay, so with horizontal, the difference is that instead of moving away and closer to, like further away and closer to, you're moving along the laceration. So same thing starts, but you're going to be near and near. And then you're still going to need to reverse your throw, right? Because you're coming back on the other side or coming back in the other direction, yeah? Ugh.
I'm sorry?
Then you're gonna advance along at the same distance until you come through the skin, and my hand placement isn't very good, so please excuse. So until you come through the skin, same thing, gonna control your needle tip. Grab it,
Oh, I see what you're saying.
same thing. So everyone see how that knot isn't flat?
Yeah.
So you keep a control of it, and you kind of like shake it until it flattens out. And sometimes you have to kind of twist it a little bit, right? Same. Same. And then you want to make sure that you don't get suture tips stuck in your subsequent sutures. So that was an excellent lesson. So you flick them out. And this little tip was stuck inside of my suture material. So you just flick it out of the knot, because you don't want it to be connected to the other suture.
So you just tied it like 3 times in a row right there,
Yeah,
and that's for the horizontal.
that's for every. It's the same thing.
Same knot.
Same knot. Yeah. So that's horizontal. Yeah.
Yeah.
Okay. Horizontal, vertical, simple interrupted, simple running, deep dermal, or and subcuticular. Those are remaining. So there's no shame as you're learning in. Like, you notice how I'm starting to work with a pretty short piece of suture material. This is probably going to be frustrating for you when you're learning, because it's harder to tie knots at the end. So we have enough suture material that you don't have to work with tiny ends, okay? So feel free to, don't hemorrhage suturing material, which we're trying to conserve as much as possible, but you don't have to work with something this short. That's not something we expect you to do as learners, okay? Deep dermal. So, who remembers the science behind this one? We talked about it in class yesterday. Or how do we think about it? Yeah, what did you say?
Deep superficial.
Deep superficial to deep.
Yeah.
And why is that?
Layers.
We're closing in layers, but it's all about where you want your knot to end up. Everybody remember that?
Yeah.
Yeah. So now this would be an inappropriate suture material to use for this if I was actually using it in a clinic setting. Well, why?
For short.
It's not dissolvable.
Right, non-absorbable, right? Nylon sutures. So what I usually do is I start on the edge of the wound that is closest to me, and I throw my deep to superficial. So you can evert aggressively on this one, and you throw in deep,
Goes deep.
and you come out. So this is why eversion is important, because you want to come out. Oh, see, I'm too far. Does everyone see where my needle, where it just popped out, like way too far up? But so you want to come out right where this border is, between the dermis and the epidermis, right? So sometimes this takes a little bit of
And then she's gonna stay in there.
practice, but oh, whoops!
You almost
I
did.
bent my needle.
Is it usually this hard?
Does the needle have a pin?
I've never seen anything do that before.
Is it usually this hard on like a
No.
person?
No.
This is probably
Can someone pass me another, maybe a 3-0? Yeah, can you pass me a 3? Thank you. Okay, so ignore the fact that the needle bent. That should not happen. I think that was just because of the material. So again, just like kind of like central lines, like sometimes the material is a little bit a little different than real flesh. So I'm switching to a 3-0, which is a bigger needle. Okay, everybody see how that needle's bigger? So when we look at this, it says 3/8 circle reverse cutting, but it's a 3-0 instead of a 4-0. So it's a much larger needle because it matches the size of the suture material, yeah? Okay, so back to business. Evert aggressively, take a deep bite, and you want to come out right where the dermis, or right where the dermis and the epidermis meet. Now see, then you want to examine and see if you popped through at any point, because you don't want a little tag of suture sticking out of the top layer of skin. Make sense? So sometimes what happens is your needle tip does something sneaky without you knowing about it, and it goes just out of the epidermis and whoop, just back in, and then you end up with a little tag of suture material on the outside, and that's going to cause infection, inflammation. It can cause the suture to migrate out and other things like that. So we don't want that. Now you're going to be, this is like one of these work smarter not harder things, because now you're in a perfect position to go shallow to deep like this with your needle, right? So again, and you want to come right across, so right across from where you put in the first suture to the other edge of the wound, evert aggressively, pop that in right at the dermis epidermis border, and flip it around deep. That's like maybe a teensy bit shallow. This is superficial to deep. So this is a teensy bit shallow, but for the purpose of demonstration, we're going to leave it. So then, everyone look. You see how I have two ends and they're inside the wound?
Yes.
When I tie this, so you pull the end all the way down. When I tie this, same thing, instrument tie. Same thing, you want the knot to lay at least partially flat. That knot pops inside and goes away.
That's superficial.
It was deep to
Deep to superficial, superficial to deep.
And then tie.
Yeah, and then you show yourself the edges of the suture. You can hold them in your needle driver, and you cut them below the edge of the skin. And then you kind of tuck that little piece in. And a lot of times, like in the ER, you're going to be using these to close like a deep layer, and then you're going to be using like a simple interrupted or a mattress suture on the surface to finish closing the wound. So you're using these to like help suck the wound together or to approximate certain layers, and then you're going to, so then that's another opportunity to kind of get rid of, if you have a teensy bit of suture material on the outside, you can kind of like pop it in a little bit and then see, I can close it like that because now that little nubbin of suture is gone. Yeah?
Is there a simple dermal suture? Or simple running dermal suture where you're not?
Yes, but we're not gonna teach that to you.
Okay.
Yeah,
Like,
but
we'll
I mean,
just go
yes,
all the way-
yeah,
we'll
you
just
could
continue.
technically continue, and there's also a locking one, so that's where you're like your pass is then like inside the original pass, so it locks in place. Same with the surface one. There's a locking surface one where your second pass is on the other side of your thread, so that it makes kind of like a loop and lock. Does that kind of make sense? It's sort of hard to talk about, but yeah, we're not going to teach you those because those are kind of like other applications. Subcuticulars? Is that it?
Yeah.
Okay, subcuticulars. Subcuticulars, the reason they're included in this class is because they're surgical. It's a surgical closure. So it's really helpful for you to know how to use them going into your surgery rotations, because you use them, we especially use them for like lap choles, other like kind of small incisions, stuff like that. And so you're closing superficial layers of skin without leaving any sutures on the outside. So they're all on the inside. They're mostly non-absorbable actually, but they just remain. And then it creates a nice wound edge and a nice clean scar. And then most of the time what we'll do is we'll put Dermabond on top of them. Yeah? So do not become frustrated by subcuticular sutures. You will get them eventually. But it's a kind of a whole different concept. So basically subcuticular is you're going to be running it kind of along that dermis epidermis border, okay? So a lot of what I learned that I found very helpful when I was learning this technique was that I learned to throw just a little bit deep, kind of on an angle, and then you come out at that border. So you're moving along the stitches. It's kind of like a horizontal mattress version of the deep dermal. Yeah?
Not through the epidermis.
Yeah, so not through the epidermis. So you're just underneath the skin. And then this is another one of those ones where you're going to come back in the other direction. And this one sometimes also it helps to make, instead of your needle driver being at a 90-degree angle to your needle, you put it at like a 45-degree angle, and that helps you achieve those angles that you're like looking for. So just across from where you were, you're going to come back in. And this one is a bit wide, actually. It's a bit aggressive. It should be a little bit narrow over throat because I'm using a 3/0 needle. It's kind of hard to, because the needle is like, more, you know, and I'm like, no, and it's like, yes. So like the needle should be a little bit smaller for this, but then you're gonna see it's hard on the skin, but it sucks the edges together. Everyone see it kind of did that on this one. So it's difficult on this skin to get a really good subcuticular, but you will know that you've done it right when the surgeon starts like humming happily to himself, because that means that you get to close and he gets to go away. And also when the skin edges kind of suck together just like that when you're done, okay? This one then, same thing, you kind of show yourself the edges, however you choose to do that. I usually use the needle driver because your hands are likely to be slippery because they're being covered in blood and body fluids and stuff. And then you cut, again, below the surface. Do not cut your knot because that's the greatest tragedy in the world, all right? And then you cry, and then you have to start over again. Same thing, sometimes you end up with a teensy little edge on the surface, so you just kind of tuck that sucker in there and put some Dermabond on top. Done. Beat to fit, paint to match. Yeah?
Okay, so I have a question.
Yes.
You start off on one side. You're going from, what is this, horizontal? Then you're going this
Yeah.
way. So you go horizontally, then you switch over and go horizontally on the opposite side.
Right,
To come out.
because
and then,
you always want to end up where you started, because that's where your knot's going to be. Because if you ended up on the other side, like if you ended up diagonal to each other, then your knot would be this huge, massive thing on the inside that would stretch a certain distance. Does that make sense? So if you came in right here, and you exited here, and then you went in here, then you would be crossing over underneath the skin, and then you would be crossing over on the top of the skin to come out. Does that make sense?
And that's what we want.
No.
No. Okay.
So what we want is to end up underneath the skin back where we started. It's always the same, even with
so
like the
going through
horizontal
here,
mattress sutures, same
making a
thing.
box.
Yeah, it's like making a little box, yeah, or a little U-turn.
Yeah.
Yeah, think about it like a U-turn, like
Yeah,
it's like a little,
U-turn,
yeah,
Did you tie?
yeah, it's tight already.
Oh, okay. But then we still have the 2 strings. and
Still
then-
two strings, still 2 strings. The only one that's any different is the running, and that's that triangular closure. That's a bit more advanced than probably what you're gonna learn today. And that's fine, like, don't worry too much about that. It will come eventually. So this is like your intro to suturing. You'll actually get some of the triangular ties, I think, next week when we do knot tying. And then again, you'll get it in your rotations. Stapling.
We had a one-line video for this.
So does the same techniques and tools that plastic surgeons use?
Oh, you want that? I got you.
The same things that plastic
No, plastic surgeons are like, they are like a whole different world. They're the ones that they use like barbed sutures, so they have a barbed suture material, so it sticks in a different way, and there's like, they have a whole bunch of different sutures. They have advanced sutures that they use that are different, yeah. Some, yes, some the techniques are the same, but some are very different. Okay, skin stapler. Okay. I mean, you can. I don't know if they'd be very happy with you, but you could. So there's 2 ways to do this. One is by yourself, where you're kind of like, you want to at least like sort of evert like kind of one edge, and then you're going to line it up. In theory, the stapler. So everyone see how it has a little arrow, a helpful little arrow pointing directly where you want the middle of the laceration to be. This is like the helpful arrow signs. Helpful arrow
That is
sign.
where it lands right in the middle.
Yeah, bam, put that in the middle. In theory, these staples will evert the edges a little bit. They're designed to do that. So you don't really need to like be aggressive about that, but you can evert a little bit, line it up, evert, line it up, squeeze the handle, evert, line it up, squeeze the handle.
Thompson, please, can you do one on this side?
Yeah, flip it.
Line it up.
Asking me for these later.
I am, but still.
Yeah, I mean, you would avert it. I just ran out of room. And notice, like, even without without me everting it, it did a pretty good job by itself, right? Then to remove, we'll do this right now. So because I'm going to reuse that little section. So this is a staple removal like device. Everyone see it has little tiny curved blades on the bottom and then a little flat blade on the top. So what it does is it lifts the sides out, and then you kind of squeeze it and just pull directly up. So all you do is you hook the little curved legs underneath the staple. Can you kind of see that? So you hook the little curved legs underneath the staple and you squeeze. And everyone see how it popped the edges out? So it pops the edges out, then you put them somewhere where you can put them in the sharps container later. I'll do one going in this direction so that with my left hand, you guys are demanding. So you sometimes it can be hard to see, and that's okay. You can mess around with it till you get it, but you want to get those little edges underneath just the staple, not the skin. Hopefully, the little curved edges. Squeeze and pop. Okay.
And this is like mostly for like superficial, right?
Oh yeah, no, yeah. Staples are always superficial. There's staples inside, but those are surgical. So those are placed by like surgical staplers. You can see them on like X-ray. They're radio opaque, and they will stay inside forever. So you never remove those.
Saves a lot of time if you just staple it superficial.
Yeah, but for cosmetic reasons, it creates railroad scarring. So it creates little railroads, and a lot of times the edges are a little tighter, so you end up with like a little bit more of a deeper like colored scar. So that's why sutures, you need to be good at sutures so you can learn how to do them on areas where you want a good cosmetic result. So the other technique is to have a friend. So your friend is going to come along. This is a surgical technique. This is what we do in the operating room. Your friend comes along. I'm just going to turn this because this is how I would be standing in the OR. Friend comes along, grabs with rat tooth forceps on both sides. So pretend this one is a rat tooth. Comes along and everts the edges for you, and then you pop a staple there. They move down the line. Evert, pop a staple. Evert. So
evert and bring them together.
Someone grab these. So evert the edges. Do it like right down here where that little nub is, so that I can reach it. Yeah. So you evert.
Like this one?
There's no waiting in surgery.
Is that how?
Yeah. Then you move this way. Everyone see how that kind of works? Can you guys see okay?
Good job,
over there?
Cam. Yes,
All right.
Cam,
Cam, you're ready.
Surgery.
Surgery specification.
There you go. Everyone get that?
Yeah.
Okay.
And this is one time use stapler.
Yeah, this one goes in the sharps container when you're done.
Don't save it. Friends trying to take it home.
No saving. Okay.
Stapling.
Did you do everything? Oh, punch biopsies and shave biopsies.
Oh, Dr. Pimple Popper.
So the punch biopsies, we're just going to kind of show you how to do them. They tend to destroy the skin, so you don't have to do one today in order to like pass the class. You just have to understand like how the materials work. Okay. So they have different sizes depending on the lesion that you want to remove, and they're very, very simple to use. They are literally like a core, or like an apple core basically, but teeny. So they have all different sizes, lots of different sizes, and they're sharp on the edge. So don't go around like tapping on this edge, because that's how you create the wound, okay? So all you're gonna do, I'm not gonna do it on the skin because I don't want to ruin my pretty new skin, but you just go like this, and it pops out
Oh.
a little piece. Yeah? Yeah.
Let's try it on him.
Shade.
Kiara.
On skin, this would come out a lot easier, so it would, like, it will pop out, and then that's the sample that you send to pathology. So it's I kind of broke it a little bit, because it's not used to taking, like, chucks. But it should pop out, like the little skin biopsy should pop out, or you can kind of gently use, like, some rat tooth to like, encourage it to come out a little bit. I just made it go further in, but that's because this is, like, not the right material, okay? So shave biopsies, this is one device you can use. You can use just about anything. You can use a plain scalpel as well. So shave biopsies, this is a nice little, like, unit that you use, but like I said, you can use just about anything. So this comes out sharp, so be careful. It has a very, 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 very sharp blade, and it's flexible. So all you do is pinch it together. Oh, sorry, you can move that. Here, put that back over there. So all you do is pinch it together, and you're going to shave whatever you want to shave off. So, like, in this case, like, if you're after this, you just kind of come in at a slight angle, and you kind of saw, and it pops off the lesion. Yeah? And then you very carefully put this in the sharps container out of your way, where you're not going to hurt yourself with it, because it is very sharp. Very, very sharp.
That's cool.
Okay?
Yeah.
Questions? Ready to go?
Yeah.
Do it!
Hey,